Welcome to episode 96 of Dermatology Weekly. I'm MDedge Dermatology Editor Elizabeth Meshkati. Coming up in the peer-to-peer portion of the program, Dr. Candrice Heath welcomes Dr. Sarah Noor and medical student Dulce Barrios, who discuss how skin toxicities from systemic cancer therapies manifest in skin of color patients. As always, the peer-to-peer portion of the show will be after the news. And in the news this week, we have a study on the risk of autoimmune diseases in patients with atopic dermatitis. But we begin with a story on the guidance provided by the American Society for Dermatologic Surgery on dermal filler reactions in patients who received the Moderna COVID-19 mRNA vaccine. The guidance refers to 3 reactions in patients who received the vaccine in the trial of approximately 15,000 vaccine recipients. No cases were reported in the placebo group. The cases were in 3 women, 2 with facial swelling reactions occurring 1 to 2 days after the vaccine was received, and another in a 29-year-old who developed lip angioedema 2 days after the vaccine. None were considered a serious adverse event, and all 3 resolved. Other vaccines, including the influenza vaccine, have also been associated with inflammatory reactions in patients with dermal fillers. In an interview, ASDS President-elect Dr. Sue Ellen Cox said that a warning about inflammatory events from these and other immunologic triggers should be a part of routine informed consent. Dr. Cox, who practices in Chapel Hill, North Carolina, is a co-author of the guidance, which is intended to alert clinicians and patients to the potential association between inflammatory events and SARS-CoV-2 vaccination in patients with dermal filler. The resolution of the inflammatory reactions associated with the vaccine is similar to those related to dermal fillers following other immunologic triggers. These triggers not only include other vaccines, but viral or bacterial illnesses and dental procedures. Typically, they are controlled with oral corticosteroids, but also typically resolve even in the absence of treatment, according to Dr. Cox. In the interview, she said the patients who have dermal filler should not be discouraged from receiving the vaccine, and those who have received the vaccine should not be discouraged from receiving dermal filler. And in a large population-based Swedish study, individuals with atopic dermatitis had almost a 2-fold risk of having an autoimmune disease. Researchers from the Karolinska Institute in Stockholm looked for associations between autoimmune diseases and AD using Swedish healthcare registry data, matching about 104,000 people aged 15 and older with about 1 million controls from the general population. They found an association with AD and autoimmune diseases as a group, with an odds ratio of 1.97, adjusted for education when compared with controls. The association between AD was significantly greater among those with 2 or more autoimmune diseases. There were also strong associations with several autoimmune skin diseases, which included adjusted odds ratios of almost 10 for dermatitis herpetiformis and about 5 for alopecia areata. There were also associations with gastrointestinal and connective tissue diseases. The authors concluded that their findings could lead to better monitoring of comorbidities and a deeper understanding of disease burden and AD pathophysiology. They added that further studies are needed, especially to identify subsets of patients with AD who are at a higher risk for autoimmune disease. And that's it for the news. Coming up after the break, Dr. Candrice Heath and Peer-to-Peer. Welcome back to Derm Weekly. It's now time for Peer-to-Peer. Please welcome Dr. Candrice Heath.
I am Dr. Candrice Heath, guest host for the Dermatology Weekly podcast, and we have an exciting episode today. We have partnered with the Skin of Color Society to highlight yet another winner from the Skin of Color Society Scientific Symposium. So I'm very eager to introduce my guests for today and jump into the topics. So first up, we have Dr. Sarah Noor. She is a dermatologist at Memorial Sloan Kettering Cancer Center in the Department of Dermatology. And we have Dulce Barrios, who is a fourth-year medical student at SUNY Upstate Medical University. And at the time of their research project, she was a student researcher at MSK. So thank you so much, ladies, for joining me on the podcast today.
Thank you for having us.
Great, great. So I definitely want to dive right in and just give our listeners the title of your project. So the title was Anti-Cancer Therapy-Induced Cutaneous Dyschromias in Oncology Patients with Skin of Color. And this project presentation actually won the best oral presentation for advancing skin of color dermatology. So you came away with a huge win from the Skin of Color Society Scientific Symposium. So congratulations once again. And what really prompted you to study this topic in the first place? We'll start with Dr. Noor for that.
We know that in general that common skin conditions may present differently in patients of skin of color. And we also know that skin of color patients are more prone to developing certain skin conditions, including hyperpigmentation and certain patterns of hair loss. And while we are aware that cancer therapies, including chemotherapies or other systemic therapies and radiation, can affect the skin, hair, and nails, little is known about how these toxicities actually manifest in patients of skin of color. And so one of the things I noticed here at Memorial Sloan Kettering when I was seeing patients on these cancer therapies was that patients who are of darker skin types were presenting more with discoloration or hyperpigmentation as their main or primary skin toxicity. But many of them didn't have any sort of preceding rash or erythema. And I think in dermatology, we generally think of hyperpigmentation as post-inflammatory. But as I said, most of these patients were presenting it as their initial sign. And for many of them, this was quite bothersome in appearance as well as symptomatic. And so this led to this idea with Dulce of looking at pigmentary changes as a result of these cancer therapies. Our sort of hypothesis was that this may disproportionately affect patients of skin of color. And it's also kind of led a little bit broadly into exploring how these dermatologic adverse events in general may manifest differently or similarly in patients of different skin types.
And Dulce, when you found out that this project was available and everything was coming together, how excited were you about this topic, and how much did you have to read to understand all of these drugs that that can cause these different rashes?
Well, yeah. Well, first I want to say thank you, Dr. Heath, for allowing us the time and the space to really talk about our project. But just to take it back just a little bit, even before medical school, I had already been involved in clinical research with underserved populations. So that's been an interest of mine even before I got into medical school. I began medical school and did like a summer fellowship kind of in research at Memorial Sloan. And that's when I first became acquainted with these oncology drugs and all the names and all the different mechanisms and whatnot. And we were characterizing the outpatient dermatology consultations for these patients in the outpatient setting that were having cutaneous toxicities. So that was a while back. But then recently, over the last year, I specifically wrote a proposal to the American Society of Clinical Oncology saying that I wanted to investigate dermatologic adverse events in patients from underrepresented populations, because really there was very little known. And then, of course, with the help and the guidance of Dr. Noor, that's how I was able to really narrow down the question to this very clinically relevant topic on pigmentary changes as a result of cancer therapy in skin of color cancer patients.
Oh, that's great. So I love the way that you were able to bring your background, some of your interests, and one of the hardest things to do is to really hone in on that research question. So definitely take some, people with experience to help you with that, but it definitely came together very nicely. And Dulce, why do you think we see so few skin of color patients represented in these oncology clinical trials. Have you spent some time thinking about why that may be?
I have spent time thinking about it, and Dr. Noor and I have discussed this, and I can speak partly to some of my experience. For example, in trying to recruit back in the day, Latino patients to participate in non-oncology clinical trials, and it was a challenge because there were many barriers. First of all, access to even knowing where these trials were taking place. Also, language barriers, cultural differences, not understanding even the language in the consent forms. And from a cultural perspective, there's some skepticism, some fear. So that's from my experience. But I know that there's literature out there in the oncology literature, specifically, that many of these trials, they tend to underreport race and ethnicity. Therefore, it is underreported. So I think it's a combination of different things. And Dr. Noor, perhaps she can add to this as well.
Yes,
Yeah.
Dr. Noor, I know that you're at a major cancer center, and I know probably a large portion of your patients have either had active cancers or have had cancer. So I would love to hear what you have to say about this topic.
So, I think some of the sort of barriers stem from socioeconomic factors and cultural factors as well. I think one of the barriers to enrollment of skin of color patients includes sort of access to these academic hospitals or tertiary care centers where several of these trials are conducted. And this lack of access could be due to sort of limitations in insurance status or even distance needed to travel or costs for traveling. Certainly, and we sort of work to address this, but language barriers and health literacy may also play a role, preventing sort of a complete understanding of the clinical trial procedures or medications, and really understanding the risks and benefits. And then I think one important aspect that to sort of emphasize is also cultural differences in health beliefs, and that includes sort of differences in trust in the healthcare system. And I've encountered this with some patients as well. And is that really and a perception that a clinical trial is experimental, and the idea that potentially patients are kind of being used as guinea pigs. And I think all of these kind of factors certainly can play a role in sort of a lack of or a less skin of color representation.
Yeah, I think that exactly, you really hit that on the head, and that is exactly what the research is showing, that's what's happening in the field. That is exactly the stories that patients tell us again and again. And I can even remember in my own family when I finally got to medical school, even dispelling some of those same myths. So those myths are definitely around. What if you don't have anyone in your family who's in the medical field who could help you really navigate that process? So that could definitely be an entirely different project, and an interesting one at that. But let's dive into some of your results. So, Dulce, can you tell us about some of the cancers that were associated with more pigmentary disorders from the anti-cancer therapies?
Sure. First, I'll just briefly summarize our research methodology, which is just a retrospective review of the patient's medical records from Memorial Sloan Kettering Cancer Center, and they had been evaluated by dermatologists between 2012 and 2019. So it encompasses a 7-year period, and we included patients who were 18 or older, who had a confirmed diagnosis of malignancy, and who had history of either ever receiving a hematopoietic stem cell transplant or who had received systemic anti-cancer therapy within 6 months prior to having been diagnosed with cutaneous pigmentary changes by the dermatologist. And of note, the results and conclusions of our study, those are in reference to an initial visit that the patients had at the dermatologist's office. And we initially investigated cancer therapy related pigmentary changes exclusively in African Americans and Asian patients, because we wanted to, as I said earlier, really look at skin of color. But actually, up until now, we've actually added more to this data because we wanted to know about any disparities, meaning skin of color versus non-skin of color. So now, Dr. Heath, to get back to your question, as far as the cancers that were associated with more pigmentary changes from anti-cancer therapies, overall, breast cancer was quite prevalent, but a significantly disproportionate number of African American women with breast cancer were affected by cutaneous pigmentary changes as a result of oncologic treatment compared to Asian patients and Caucasians. And when I'm saying significantly greater, that's 54% in African American women with breast cancer compared to, for example, 41% in Asian patients and Caucasians, 42%. And of course, there were other malignancies that we observed, predominantly solid tumors overall, including gastrointestinal, gynecologic cancers, and lung cancers, among others. And just to mention the type of cancer therapies that were highly associated with these cutaneous pigmentary changes, cytotoxic therapy by far was the one that was most likely to be the culprit for these cutaneous pigmentary changes, and that there were no differences by race there, cytotoxic chemotherapy.
And Dr. Noor, do you have anything to add to that summary of results?
Well, I think Dulce was also going to sort of comment on some of the I think in terms of sort of more of the pigmentary changes that we were seeing more, hyperpigmentation than hypopigmentation. But I think, in terms of the cancer, as well as what we were seeing, I would say that for the majority I would say that sort of more chemotherapies were probably, most associated in solid tumors, but we were also seeing pigmentary changes in patients who were receiving, for example, epidermal growth factor receptor inhibitors and were developing more of an acneiform rash, and also pigmentary changes as sort of a response to radiation and post stem cell transplant as well with GVHD. So I think, and I think Dulce will talk a little bit about this as well, but I think we are seeing sort of hyperpigmentation in some of more of what we consider typically inflammatory etiologies of rash.
So of course, the researcher in me, my wheels are turning. So just listening to your data, I'm thinking about also the cancer data that talks about Black women, specifically African American women with breast cancer and how aggressive it can be. Were there any, we have to go back and look, were there any differences based upon the stage, that of the cancer that they had? Like, when did the hyperpigmentation come, or was it the ones that were diagnosed later or earlier? I don't know, but great research begets great research. So that's a great sign. And I'm sure you thought about these things too.
And yeah, I think that's a very interesting point that you bring up. I think, and the answer is, we and that's really kind of the key is to see if we can identify risk factors at some point that may predispose patients to developing some of these skin toxicities or types of skin toxicities. I think there is there are literature about sort of racial and ethnic differences in cancer drug like metabolism, and even like tumor expression of certain markers when we're thinking about more immunotherapies. And so all of these obviously have implications for how well patients respond to therapies, but also in the development of toxicities. And so, I think that this project is kind of a start to looking into some of that.
Definitely. Very, very interesting. And Dulce, you kind of hinted at it, but can you talk about why you think hyperpigmentation was way more common than hypopigmentation? And also kind of talk about some of the exact presentations of the conditions that you were seeing.
Sure. So yeah, to start off, I'll say that hyperpigmentation was by far more prevalent, more common than hypopigmentation. Initially, just in African Americans and Asian patients, we saw was a prevalence of a proportion of 94 hyperpigmentation to percent to 6% hypopigmentation. And then when we added the Caucasian group, it really stayed in that same prevalence proportion. So it was 95 hyperpigmentation and 5% hypopigmentation. As far as mechanisms, I can propose some theories. If there's an inflammatory response, there's increased melanocytic activity, but in darker skin, there's perhaps already more melanocytic and pigment activity. Therefore, it's more pronounced. That's from a very simplistic point of view that I'm expressing that, but we have to take into account these cancer therapies are all working very differently from acting on different receptors and mechanistically very different. Now, hyperpigmentation was associated with other types of adverse events. For example, as Dr. Noor alluded to earlier, acneiform rash. So in African Americans, we saw that the prevalence of acneiform rash that presented with hyperpigmentation was disproportionate, also more prevalent. It was 20% compared to 4% in Caucasians and 1% in Asian patients. So that's quite a difference. And also hand-foot syndrome, that's another type of cutaneous toxicity that we see with the cancer drugs that was concurrently observed with the pigment alteration. So these are some of the presentations. And then among the hypopigmentation disorders, which were very few, as I said, only 5% overall, we saw, for example, vitiligo, like depigmentation, a GVHD kind of reaction. And we saw more of those cases in African Americans. So there's definitely more to learn about mechanism and how and why it presents this way. But I think we are at a good point where we know how it's playing out in different skin types.
And Dr. Noor, it looks like you want to jump in.
I think that, more needs to be determined about sort of, the etiology. I think certainly some of this hyperpigmentation is post-inflammatory, but in some of these were sort of the initial clinical presentation.
And for dermatologists that are taking care of patients on similar medications and who go on to develop pigmentation issues, how should they think about treating the patients? What are some of the things that you did, Dr. Noor, to treat your patients, or what did some of your colleagues do to treat the patients in your study?
So, I think one of the, main takeaways is that that sort of came from looking at the treatment results and what different dermatologists used is, and Dulce will also mention some of this, is that nearly 50% of these patients didn't receive any pharmacologic treatment. They received sort of guidance with the assumption that most of this may be post-inflammatory hyperpigmentation, and so some of them were given more things like and important things to counsel patients on, like sun protection and sort of in guidance in that respect. But I think one of the main takeaways that we can sort of gather from these results is that we really need to kind of understand the pathogenesis of or etiology of this discoloration, because I think when this is kind of the initial presenting feature, it's possible that some of this is, even though it looks more just like hyperpigmentation on the skin, that there is some underlying inflammatory process going on. And so using tools that we have, including skin biopsies, and we have, here availability, some of these sort of non-invasive imaging modalities that can sometimes guide that as well. But this is sort of, very important because the treatment approach for something that's primarily inflammatory versus post-inflammatory hyperpigmentation would vary. And so I'll let Dulce sort of add to what our results showed in addition in terms of the management.
Sure, yeah. So I definitely, it was a key point in our findings that such a large proportion of the patients were not receiving pharmacologic treatment. Among the ones that did receive treatment, options included topical lightening agents, topical anti-inflammatories, some antimicrobial agents, for example, as I mentioned, the acneiform rash, so that in conjunction with the pigmentary change, but that was being treated in conjunction with the pigment disorder. And so I think most strikingly, I can say it, it was just a striking finding that such large proportion were not receiving pharmacologic treatment. And some people may ask, why is that, right? It's not on purpose. It's just perhaps it's under recognized. Perhaps the patients themselves are not speaking up as to how it affects them. Perhaps we just don't have enough options. Or even when you give a skin lightening agent to someone with hyperpigmentation, but then becomes hypopigmented, that may be a worse outcome. So there's just so much to really find out to what is the best management. There's more that we don't know than what we know.
Yes, that definitely seems like a theme when you're talking about pigmentation disorders and skin of color. We definitely have a lot of work to do research-wise in that area. So, what else do you think that practicing dermatologists and residents in training should really take away from your research? And I'll let Dr. Noor go ahead and answer, and then we'll let Dulce add to her comments.
So I think, in addition to recognizing that this might be a clinical presentation, I think just kind of broadly recognizing that maybe dermatologic adverse events may present differently in patients of skin of color. And it's important to understand the pathogenesis of these pigmentary changes that can help sort of guide management. And also, identify kind of a larger goal would be to identify patients who are at risk for developing these changes that will help guide earlier treatment and have an impact on quality of life. But I think this can also be broadened to looking at racial and ethnic differences in the presentation of skin toxicities in general, including hair loss. And, I think sort of in addition to understanding how the clinical manifestations may be similar or different, the other sort of important thing is understanding how differing skin and hair care practices in patients of different races and ethnicities can sort of impact the diagnosis and sort of the management of these adverse events. In the field of dermato-oncology, there are some algorithms for sort of prophylactic and active management of some of these toxicities. And, I think they may not necessarily, for example, and this isn't really the focus of, but for example, like scalp cooling, which is used to prevent chemotherapy hair loss, may not take into account some of these differences in hair care practices. So I think just having sort of recognition that maybe these toxicities might present differently and having kind of a low threshold to do some biopsy and additional testing to really get to the bottom of the diagnosis.
And I guess what I'll add, which I just want to sort of bring it back to the main findings, just to recap, I want to reiterate that in skin of color cancer patients, but actually among all the cancer patients receiving treatment, hyperpigmentation is more common than hypopigmentation as a result of these therapies, regardless of race, ethnicity. However, the prevalence of dyspigmentation, it appears to be much higher among individuals of skin of color, including African Americans. So at least 9% in African Americans and at least 5% in Asians and less than 1% in non-skin of color. So that's very important. So the disproportion that we had seen in the non-oncology world, we see here as well. Hyperpigmentation affects skin of color disproportionately, much more so. Second, I wanted to emphasize, again, skin of color women with breast cancer, particularly African American women, they may be at higher risk for developing skin hyperpigmentation as a result of their oncologic treatment, particularly cytotoxic chemotherapy. And lastly, based on severity grade, which in the oncology field, there's the common terminology criteria for adverse events, and there's grade 1, grade 2. And just quickly, grade 1 is when the dyspigmentation covers 10% or less of the body surface area. And grade 2 is when it covers more than 10% and it tends to be associated with a negative psychosocial impact. And what we found is that there is a greater proportion of grade 2 dyspigmentation occurring in skin of color cancer patients compared to non-skin of colors. So when we take that disparity combined with the high prevalence of hyperpigmentation, the lack of pharmacologic intervention, this really calls for additional prospective studies, particularly to assess impact on quality of life and to explore mechanisms and to propose tailored management options.
Okay, I think those are amazing takeaways. Thank you so much for joining us today. And again, congratulations on your winning research poster. You won the best oral presentation for advancing skin of color dermatology during the Skin of Color Society's Scientific Symposium. And thank you for joining us today, Dr. Sarah Noor and Dulce Barrios. We definitely enjoyed you today. And I am Dr. Candrice Heath, the guest host for Dermatology Weekly. Thank you for tuning in, and we will see you next time.
That's it for episode 96 of Dermatology Weekly. The peer-to-peer portion of the show is produced by MDedge editor Melissa Sears and editor Alicia Saunders. All of our podcasts are produced by Nick Andrews and MDedge executive editor Kathy Scarbeck. I'm Elizabeth Mishkati, and this is Dermatology Weekly.